Kathy is a speech-language pathology therapist and has been scheduled to conduct a start of care OASIS for Mr. M, a former patient who has just been released from a rehab hospital. Mr. M suffered a CVA in February and was hospitalized. After his original hospital discharge, he was sent home where he lived with his wife and adult son and began receiving home health care for rehabilitation and assistance with activities of daily living. His original plan of care included nursing, physical therapy, speech-language pathology, and home health aid visits. Speech-language pathology was involved to provide therapy to improve speech and swallowing. In April, Mr. M developed pneumonia and was re-hospitalized. After a short stay, followed by several weeks in rehab, Mr. M was again discharged to home with his wife and son. Mr. M is still using a walker. However, due to significant improvements in his functional status, the only home health care discipline ordered this time was speech-language pathology to continue with therapy for speech and swallowing. As Kathy reviews the start of care OASIS items and the comprehensive assessment, she has several questions about M1910 on falls risk assessments. She discusses her questions with the nurse clinical supervisor, Anne.
Hey, Anne. I'm a bit intimidated about doing Mr. M's start of care assessment. In particular, I'm worried about answering the OASIS falls risk assessment correctly. Could you give me some advice or guidance on this?
Sure. What questions do you have?
Well, to start with, why does Medicare want me to do a falls risk assessment? I'm not a physical therapist.
Well, CMS is interested in promoting patient best practices across disciplines and across healthcare settings. While they don't require that agencies perform falls risk assessments for patients, they're interested in measuring how many patients received a formal assessment for falls risk, a best practice. Our agency feels strongly that it's good clinical practice to do a falls risk assessment for all of our elderly patients, regardless of the disciplines involved with their care. We have a policy that states that all patients 65 and over will be assessed for falls risk at start or resumption of care. We've incorporated a formal falls risk assessment tool into our documentation forms to make it easier for any discipline to complete the questions.
Is that the timed up and go or TUG test listed on the form? Why do we use that tool?
To be able to respond yes on M1910, CMS guidance states that we use a multi-factor validated standardized tool, which is defined as a risk assessment instrument that was scientifically tested and validated as effective in identifying falls risk in a population similar to our patients.
So by completing the TUG test, I can answer yes to M1910?
Well, not exactly. The TUG test only evaluates one aspect of fall risk. However, we also collect data on patient history of falls, perform a medication review, and evaluate the patient's home for environmental factors that put the patient at risk for falls. When you put all those things together, that meets CMS's definition for a multi-factor falls risk assessment, which is that at least one factor in the risk assessment be done using a standardized tool.
I'm just not comfortable answering all those questions. I'm not a nurse or a physical therapist.
The questions from the TUG test aren't specific to a single discipline, so any discipline should be able to use them. The environmental assessment and patient history of falls can be answered by any discipline as well. Because many clinicians who aren't nurses aren't comfortable doing the drug regimen review, you can write down the meds and have me or one of the other clinical managers do the review. We'll follow up with you about our findings so that you can respond to the OASIS questions. CMS permits collaboration across disciplines as long as a single person takes responsibility for completing the OASIS.
How do I answer the questions if the patient is bedbound?
Well, that isn't the case for Mr. M. However, if you find yourself in this situation with another patient, you need to document that you were not able to complete the timed up and go test due to the patient being bedbound. For M1910, you'd need to document 0, no multi-factor falls risk assessment conducted. This doesn't violate our policy because you'd be documenting a valid reason why you didn't complete the assessment.
If I find that Mr. M is at risk for falls, then what do I do?
Well, then you need to identify falls prevention steps in the plan of care. You can consult with me or one of the other nurses or PTs. The falls prevention plan should be aligned with the falls risk assessment findings. For example, if you find that Mr. M sometimes forgets to use his walker when getting out of his chair, the plan of care should include some kind of reminders on walker use.
That sounds reasonable. I'll go do the visit now.
Great. Let me know if you want to go over your findings when you're done, so I can help you develop a plan of care.
I did the visit for Mr. M yesterday. Can we talk about it for a few minutes?
Sure. How did it go?
He's doing so much better. His speech has improved, but I'll still need to see him twice a week to work on speech and swallowing.
That sounds good. How did the falls risk assessment go?
Well, he does a good job of remembering to use his walker in the house, but I saw throw rugs on the floor that could be a problem. He hasn't fallen again, but the timed up and go test, well, it took over 30 seconds to complete. And he has a history of falls, so I think he is still at risk for falls. He also has a lot of medications on this list. Can you or one of the other clinical managers do the drug regimen review?
Yeah, I can help you with that. Yes, this certainly is a long list of medications. And you know, patients with 4 or more meds may be at higher risk for falls. Some kinds of medications, like sedatives, increase that risk. I see that he has an order for something to help him sleep. So I agree with you that he should be considered at risk for falls. What would you recommend for falls risk prevention?
I would recommend that the family create clear paths without throw rugs from the bedroom to the bathroom, kitchen, and family room. They need to ensure Mr. M always uses his walker and maybe assist him if he walks around the house after he has taken his sleep aid.
Yeah, that sounds reasonable. How are you going to document your recommendations?
I'm going to contact Dr. Williams this morning to discuss the speech and eating therapy plan of care. When I talk to her, I can let her know that Mr. M is still at risk for falls and that I'm going to teach him about the need for clear pathways and using his walker.
That's exactly what I would advise. When you call Dr. Williams, it may be helpful to organize your thoughts in the SBAR format, pointing out situation, background, assessment, and recommendation. We've found that this is very helpful for communications with other healthcare team members. Then don't forget to put the falls risk interventions on the plan of care that goes in for Dr. Williams' signature.
Oh, that's right. I'll make sure it's all on the plan of care. Thanks for your guidance, Anne.
You're welcome. You're doing a great job.
Our third scenario looked at a speech-language pathologist gaining confidence in her ability to respond to the OASIS-C start of care items. She begins by asking for guidance on how a clinician who is not a physical therapist should approach the item on falls risk assessment M1910 and why a formal falls risk assessment has been included in their agency's start and resumption of care assessments. Her supervisor explains that Medicare is interested in promoting patient best practices across disciplines and across healthcare settings. While Medicare doesn't require that agencies perform falls risk assessments for patients, they are interested in measuring how many patients received a formal assessment for falls risk, since it is considered a best practice. This agency's policies state that all patients 65 and over will be assessed for falls risk at start or resumption of care, and they have incorporated a falls risk assessment tool into the documentation forms to make it easier to complete the questions. Although a timed up and go, or TUG test, does not by itself constitute a multi-factor falls risk assessment, it fulfills CMS requirements when combined with an assessment that examines other factors that can influence falls risk. The supervisor explains that their falls assessment is discipline neutral. Questions from the TUG test and the environmental assessment and patient history of falls can be answered by nurses or therapists, including PTs, OTs, and speech therapists. For the drug regimen review, the clinician can write down the medications and have one of the clinical supervisors do the review, since CMS permits collaboration across disciplines as long as a single person takes responsibility for completing the OASIS. In cases where the patient is bedbound, the clinician is directed to document why they were not able to complete the Timed Up and Go test in the care notes and mark 0, no multi-factor falls risk assessment conducted in M1910. Our scenario concluded with the supervisor helping the speech therapist to develop a plan of care that incorporates falls prevention steps that are aligned with the clinician's falls risk assessment findings. The speech therapist is reminded to use the SBAR format to organize her thoughts, pointing out situation, background assessment, and recommendation, and to make sure that the falls risk interventions are put on the plan of care that goes to the doctor for his or her signature. This concludes our presentation focused on how to accurately report selected OASIS-C process measures and use that information to attain the best possible outcomes for your agency's home health patients. We welcome your comments on this program and your recommendations for future training. We hope to get your thoughts on how effective this session has been in improving your understanding of OASIS-C, how to complete the OASIS process items, and the rationale behind them. You may send your comments to CMS at the address shown here. Thank you for your time and attention.